All right, so hopefully I've got my volume adjusted. Nope, probably don't here. Let me see real quick. There we go. Um, okay, so hopefully my volume's adjusted and everything looks good. This afternoon or this morning, we're going to be talking about why I'm doing VBACs after multiple cesareans. So this will be the main topic of this conversation. We'll get slightly into signs and symptoms of a rupture, how many times I've seen rupture, and how many times I've done a VBAC or VBAC after many, many cesareans, why I learned it. We're going to tell some stories here. But first, we're going to start with this, and hopefully I have this big enough here. That kind of makes me a bit nervous. I'm not very good at this whole, let's say, full screen. Maybe that'll help. At least it's going to help me read it. Okay, so we're going to start with not the computer board. We're going to start with the story first. So back about 12 years ago, I was very, very nervous as a midwife. I was a young midwife. I had just really started off attending births at home. I was trying to get my quote unquote numbers for NARM. At the time, I was very much seeking my CPM. But at the time, I had 6 children at home. I had a husband that wasn't very attentive to children. Well, this is a whole long story, but I did a midwife for quite a while, but I was still very nervous and still very young and midwifery and hadn't caught very many babies. I ended up getting a divorce from that husband, marrying another husband. And right before I married him, I decided that I was going to alter or change, transform my entire life. And I was going to start systematically getting rid of the fear I had. Well, one of the biggest fears I had was being a midwife. I was so afraid of postpartum hemorrhage. I was afraid of just so many things. I was afraid that if I had to resuscitate a baby, that I wouldn't be able to. So those were the motivating factors for my travel to Uganda. So the thought process was I was going to be working at a hospital in Uganda called Mbarara University of Science and Technology. And this was a teaching hospital that trains lots and lots of doctors, lots and lots of midwives. And I thought, great, I'll go there. I'll have the benefit of lots of instructors around me, lots of hands-on experience. And that was kind of my thought process, is I would just get in there and see if I really had what it took to be a midwife, because you don't really know until you're actually handling a postpartum hemorrhage or until you're actually handling a baby that needs resuscitation. So here we go. This is the story that I want to tell you from there. So I had been working in this hospital for a little while, and there was a young woman that came in, and she was screaming and jumping around and carrying on. And I went to assess, she was very, very pregnant, and I went to assess the baby, and I couldn't find heart tones. Well, this woman was very, very scared, and she was jumping all over the place and hitting at me and kicking at me. And was unusual even for there. I mean, you don't have a point of reference that they're very polite and very quiet. So this was very unusual to have this occurring in my world. And I was trained just like every other midwife. I knew she'd had a previous cesarean. According to her record, she'd had a cesarean 10 months prior to this date. So that tells me that her chances of rupture were much, much higher according to all the books and the research I had done. And so as I'm watching her and she's freaking out and I can't find heart tones and her first baby had been stillborn, I got very, very scared, and I sent her in for a repeat cesarean. Now, I will tell you that I wish that I spoke Swahili, and I wish that I could have calmed her down. And hindsight is, I wish I was better for her. None of the other doctors there was about 12 other doctors on duty, and none of the doctors there wanted to do anything with her. And when I decided that it was just time to send her in for a repeat cesarean, they just did so. But there in Uganda, they don't have a whole lot of scrub nurses, and they don't have a whole lot of anesthesiologists, and they don't have a whole lot of surgeons. It's a training hospital, so most of the doctors are still not quite to that point, and the doctors who are the ones who are instructors and are busy in the classrooms. So I was obligated to and basically scrub in and assist at this repeat cesarean. So this woman's body to me looked like she was about 13 or 14 years old. She said she was 16, so that's not too far off, but she looked incredibly young. and her breasts had never quite developed all the way, so they look like little breast buds. They look like little donuts underneath her skin, and she's just very, very young, very, very scared. No family, no husband, nobody there to help her with this. We went into the OR. As soon as they started prepping her, she calmed right down and laid down, even though she had had no medication. She just knew the baby was going to come out, and all of a sudden she was fine. So I get inspected to make sure I've, scrubbed up and put all my attire on. And I wish I could find those pictures. It was really funny looking. I mean, I had like 50 layers on. I showed up into an OR. And it was just me, the surgeon, and the anesthesiologist. And the surgeon and I were the ones responsible for actually hands on the woman, other than the anesthesiologist who was just doing the anesthesia. So basically, we both get into this OR, and I am not a surgical nurse by any stretch of the imagination. The doctor's aware of this. Everybody's aware of what education I do and don't have, but they just needed an extra set of hands, and I was willing to do it. So we get in there, and the doctor cuts her open and starts separating her skin. Now, we're not into the uterus yet, and he exposes a large portion of the uterus, and I have the retraction clamps. I am pulling her skin apart. The doctor now has a section of her uterus about this far exposed, and he is looking for the old incision. He's grabbing hemostats, and these hemostats are like little, well, hopefully you guys know what hemostats are. They're like scissors, but they have little flat teeth on them. It's for pulling skin, for clamping things off. And he has two pair of hemostats, and he's pulling catty corner on this woman's uterus to see if he can see evidence of the old incision. He can't find it. So he takes a rollery blade. It's not a blade. It's a roller, and just rolling it up and down over where he thinks the incision should have been. No evidence of an incision. Now, this is just a reminder, this is 10 months post first cesarean, and this is a young, not as well nourished, should not be as well nourished as an American child, as an American young woman. Everything that we've read and everything that we know. Anyway, no evidence of this incision. None. Nothing. There's none. And so after just a couple minutes of looking for this incision, he looks to me and says to me, I'm going to make a new incision. I'm just going to assume where the old incision would have been, and I'm just going to make a new incision. And so he, cuts into this woman's uterus. And after he cuts into the uterus, he kind of looks at it and kind of examines to see if there's any scar tissue where he cut, to see if there was any evidence of the old incision where he cut, because he needs to cut that away so that he has fresh edges. He finds no evidence, cuts away nothing. He reaches in, he pulls the baby out, he hands the baby to me. My job is then to run off with the baby and resuscitate the baby while he sews mom up. Okay, so I run off, I do what I'm doing. I don't get to see anything else at this point. I'm in the other room. The warmer is in a side room, and all my resuscitation equipment's over there. The medications they use on the baby really puts the baby out, and they need a lot of resuscitation. Okay, so we had to be fast. Now, the next morning, I go to the OB meetings that occur every morning, and I go in, and I'm respectful and usually just sit in the back and, shut my mouth and learn what I can. And each case from the day before comes up, and each case that they think they're going to face that day come up. Okay. So as this case comes up, the doctor, reviews his paperwork and and talks about it and says, no evidence of the previous incision was found, And he's going through it all. And my brain is just rolling with the possibility. Like, what I've learned here in America is that there's a window, and that, there's scar tissue, and you can rupture, and all of these things, and it's evident. And when we open her up, it's, all of these things. And that's not what that I saw in person, and it's not what they were talking about. So I interrupted everybody. I raised my hand and I asked to speak. They thought I was kind of weird for raising my hand, but that's okay. And I just point blank asked them, I was like, so how often can you not find evidence of the old incision? And the answer was 98% of the time, there's zero evidence, regardless of how close the surgeries are. And then I asked them how often they see an actual rupture. And this was just eye-opening. And they actually said that they rarely see rupture in vaginal births from previous cesareans, but they do see ruptures when they cut the cesarean open a second time or a third time or a fourth time. And at this point, I'm, like I said, that, the reason that I went to Uganda to begin with was I felt like I was a very new midwife and I needed a lot more information, I needed a lot more data than I was getting from American schools. I wasn't thrilled with this process. This answer did more to baffle me and to upset me than I can possibly explain to you. My sister had 2 cesareans, and I thought, well, now that you've had 2 cesareans, you're never gonna have a vaginal birth, and my mindset was very much there. Anyway, I'm sorry for interrupting this conversation so much. So I come home and I've either been lied to by the American schools, or in the American, just the whole way the ACOG is run and the whole discussion that we have around VBACs and they're around repeat cesareans and whatnot, or I've been misinformed there in Uganda. There's one or the other. So when I came home to America, I figured that there was more learning that I needed to do. So I started buying old Williams obstetrics. I think I have a few here. I actually have a ton of them here. So I started buying all these old Williams obstetrics. I see that one there. Okay, no. And one of the things, sorry, I have a whole stack of books beside me. So here's one of them. I have I think I have 8 or 9. I started buying all the old Williams obstetrics and I started looking in them. And everything from the 15th edition down to the 1st edition has this exact word for word, same punctuation, everything. It's like literally they just cut and paste, and it was a cut and paste the same as we do today, but it was written, transcribed exactly the same. Is what is actually located in, here's another one here. I have 2 right here in front of me. This is another one. I have the rest in the office. But it was actually what's written here in front of you. And it collaborates exactly what we were told. Let's see if I can make this a little bit bigger. Exactly what we were told, or what I was told in Uganda. And I want to read this to you, and I'm going to decipher things for you just a little bit, just in case you don't have that background I do. And just make sure you understand everything that I'm saying here. Okay, so this is what's in here and how it describes how a uterine, how a cesarean section, or how the uterus heals itself. Okay, so it says healing of the cesarean section scar. And I try to make myself slow down because I've read this to people about 50 times at least. Oh, probably 200 or 300 times. So I'll make sure I slow down. So little information on the subject has been garnered from studies of cesarean section scars. Williams, which is Williams obstetrics, believed that the uterus heals by regeneration of the muscular fibers and not by scar tissue. He based his conclusion on a histological examination of the site and the incision on the time of repeated sections. Usually shows no trace of the former incision, or at most an almost invisible linear scar. Wait, what? Folks, they're saying that they cannot find the scar, and this is from the 80s on back. Okay, this didn't change until much later in the newer textbooks. And by the way, I bought the newer textbooks too, and this is completely omitted. Like, this section doesn't even exist in the new textbooks. Okay, let me continue here because there's a few more of the conversations I would like to have with you, and I really want you to kind of get, because the purpose behind this school is to erase that fear that we've been instilled with. Okay, so here we go. Let me go second. Okay. Second, when the body of the uterus has been amputated, cut off, no scar is visible after fixation, cut into little slices, or only a shallow vertical furrow in the external and internal surfaces of the anterior uterine wall, with no trace of scar tissue between them. Okay, mark my spot here. So what they're saying is that muscle fibers and scar tissue are 2 different tissues. We can actually take scar tissue, which is a type of connective tissue. We can put it on a slide and put it in the microscope and tell what kind of tissue it is, and even where it's located. Muscles do not heal with scar tissue. they actually replace themselves with more muscle tissue. And I want to kind of review that to you too. This is why I don't call it a uterine scar. It's not a scar. It's been replaced. It's actually proliferated. And I'm going to go through and it's going to explain it one more time for us. But I kind of want you to get that. And I want you to start releasing that possibility of it being a scar. The skin has a scar because that's how skin repairs itself, right? The skin does have a weakness and the skin does have connective tissue in it. That's how skin replaces itself, it repairs itself. That is not how muscles repair themselves. And we have lots of evidence in this in science. We have like muscle bodybuilders, they are tearing their muscles all the time, and it doesn't just get weaker and form connective tissue, it actually builds more muscle. So why would we think this muscle would be different than that muscle? And we're going to be talking about the physical structures that we have in the body and the differences between things like smooth muscles and round muscles. We're going to be talking about those things at a later date, not today. Okay, Schwartz, Paddock, and Bortnick, however, concluded that that healing occurs mainly by the proliferation of fibroblast muscles. They studied the site of the incision of human uteruses, I would say uteri, some days after cesarean section, as well as in the uteri of experimental guinea pigs, rabbits, and dogs. In other words, they cut open a woman again and looked at the scar tissue just days after, and there wasn't scar tissue. They were looking for it, and it was actually already muscle tissue. Okay. They observed that as the scar shrinks, the proliferation of connective tissue becomes less obvious. Schwartz, Paddock, Bortnick's conclusions appear justified by the histological examinations, particularly in the cases of adequate approximation of the myometrial edges. Myometrial is the edges of the cut, the muscles, the edges of those muscles. And approximation means to bring them together. Like, how well were they approximated? In other words, how well did the surgeon get the muscle that was attached to this muscle to touch that muscle again? Okay, that's what it means. If the cut surfaces are closely opposed, the proliferation of connective tissue is minimal, and the normal relation of smooth muscle to connective tissue is gradually reestablished, accounting for the occasional absence of even a trace of the former incision. Accounting for the occasional absence of even a trace of the former incision. Even when the healing is so poor that marked thinning has resulted, that's a window, the remaining tissue is often almost entirely muscular. The fundamental weakness stems from the failure to approximate carefully the inner margins of the incision or from formation of the hematoma in that area. Additional factors affecting the healing of wounds in general are likely to play a role in the final result. In an effort to assay or to survey the effects of steroids, they actually injected large doses of hydrocortisone and cortisone acetate into cats for over a month after cesarean sections. On examination of the uteri, he could find no difference in healing between the treated cats and the controls. Whoa. Whoa. Okay. Oh. So in the American clinics, previous cesarean section is the most common indication for cesarean section. At the Kings County Hospital, for instance, it was the indication in 47.2% of 1,000 consecutive sections. So it goes on to talk about it. Guys, what this is saying to you, it's usually, typically, if there is a failure or uterine window, it's because of the doctor, the surgeon, not doing a very good job. And most of the time, that's not what we see here. So this is gonna, so much here. Look up here. So the dehiscence of a cesarean section scar is much more frequent than actual rupture occurring, according to Lane and Reed, in 2.7% of the 583 patients patients delivered by subsequent section. Got it? So during a repeat section, what they observed was that dehiscence was more likely than rupture. And that makes sense. If you have layers and layers of muscles, layers and layers of balloon, and you start cutting through it with a sharp knife. The balloons are really expanded and have water and a baby in them. You start cutting through it with the scalpel. You can expect some tearing to go. And a dehiscence is not a rupture. It's where the muscle fibers have torn, but not all the way through. Okay. It seems to be somewhat more frequent with the lower segmented scar, and is remarkable that these separated scars covered only by the perineum frequently appear to cause no difficulty in labor or subsequent dictum. Once a cesarean section, always a cesarean. This is not true, guys. And so one of the things that we knew from the beginning, like when we first started doing cesareans and up until the 80s, if a woman was, had a cesarean, she was expected to vaginally birth. And she wasn't even given any special circumstances. It was just she was expected to vaginally birth. Insurance companies at the time also expected her to vaginally birth because it was more expensive to birth via cesarean. At some point, that kind of altered, and there kind of be malpractice insurance and other insurances and pharmaceutical companies, and it became a bigger game, a more political game than just a woman is expected to birth. So a lot of you have come to my school because you realize I'm doing some things that maybe aren't super supported by the outside establishment. And that is, I've done VBACs after, 2, 3, 4, 5, 6, 7, and 8 cesareans. And I've not seen a rupture, not one time yet. And more than 60% of my clientele is VBACs after multiple cesareans. So during this period of time, I have to tell you that I have caught babies. I've caught twins on a VBAC. I have caught babies after 7 and 8 cesareans. I have caught babies for women. One the other day was a woman had 3 cesareans and was over 400 pounds. And I caught her baby, and the baby was 11 pounds, 1 ounce. Beautiful, beautiful birth. And we'll talk about that and the differences between women with that weight level and women with a smaller weight level, and what the differences I observed, and what we can learn from physicians, and how we would handle these women differently to give them the outcome that they're asking for, and what kind of criteria we need. But we'll talk about that another time. I need to stay on subject here. So let's talk about the criteria here for a VBAC. I do not like the criteria we're using now on these different scales of, your chances are 82% or 2% or 4% or whatever they come up with. I don't think that they're ever really looking at this, first of all, and I don't think that they're really evaluating the client's ability to heal. So the things I like to use to evaluate whether or not a woman is a candidate for a VBAC is, 1, does she want one? Every woman deserves to have the birth of her choice, and she gets to be the one to assess her risk, whether she wants to take that risk or not that risk. My job is just to advise. Okay. And there's been a few that I was like, I'm not sure I want to do this, but she really did. There was no one else to attend her, so I just did, and ended up being a wonderful outcome. But healing. Did she diet really hard to get back right after having a cesarean? If she did, then we can start to assume that she may not have had the nutritional benefits of developing good, strong fibroblasts. That being said, though, if she didn't right away and she did later on, like a year later, then those fibroblasts would strengthen themselves, just like your muscles would strengthen themselves. But I really do take nutrition in this to be a big, big pivotal point. Like if a woman's not taking care of herself nutritionally, she's probably not a candidate for home birth. You have to be a very responsible for yourself person to even want to consider a home birth. This should never be done just because it's a fad or because it's fun or interesting or there's a nice story to tell. This should be done because you're really committed to your overall health. Okay, so other factors. I like to grab a hold of someone's arm. This is going to sound really ridiculous, but I feel like this is actually a better measurement. And I like to feel their arm muscles. When I grab their arm muscles, do I feel a substantial muscle? Can I make out the muscles in her arm? Or do I go straight to bone and it's mostly, there's no power in that? that gives me an idea if we have any sort of neuromuscular autoimmune disorders. That kind of gives me an idea on her body's ability to form muscles and her body's ability to repair muscles. And I don't use that as ironclad. I don't risk people out. It's a conversation. It's a kind of an overall in my brain, really being with my client and getting to know them physically. So anyway, a lot of conversations there. I think that's probably those two factors, nutrition and evaluating their own muscles, are kind of two factors. I like to evaluate also what caused their previous cesareans. So I've had 3 women in my career that I would think that probably should continue to have cesareans, and one of them, and if she ever watches this, I apologize. You gave me permission a long time ago to talk about your story a little bit, but she was born with a lot of physical deformities, where she's actually blind in both eyes, and it has some structural deformities. She's had 4 cesareans to date, and I tried to help her have a VBAC. The problem is that she never went past that point. Like, she never dilated. We spent 4 days waiting. We, kept an eye on the baby, kept an eye on mom. Everything was fine. But she got exhausted and went in, and there was no dilation whatsoever. So, for her, I think that we are not in a condition, because we have a structural issue here, to have a vaginal birth. Another woman was part of a religious group where they were inbreeding for many generations. And also, when I evaluated her pelvis with a vaginal exam, after several days of labor, came to the conclusion of there was not enough room for the baby, and there was no give. She had a fused pelvis. There was no give there. She should probably also have a repeat cesarean. And then I have only one woman with zero physical deformities that I was aware of, zero abnormalities that I could find. And again, after more than 24 hours of labor, I finally evaluated her via a vaginal exam, and again, could barely fit, I could not fit 3 fingers in there, and I had no give. She's had 2 cesareans at this point and is actually currently pregnant again. And I'm hoping that we could find some way to evaluate that better. But we also know that through history, and there are women who have fused pelvises, and there are some deformities that do not allow women to birth vaginally. But as a whole, there are not a whole lot of other reasons why I would not at least attempt a vaginal birth after multiple cesareans. Some of the other reasons that I would probably hold off on a VBAC for someone, if their diet is crappy. One woman, I turned her down because I didn't even let her hire me. She talked about eating, McDonald's for breakfast every morning and Wendy's for lunch. And she, they had a dinner from, a microwave type of dinner. That's not food. And I wish I had the time to, educate her on how to cook and how to care for her family better. But I did not have the time at that point to do so. That's one of the reasons why I want heritage midwife to be a thing. We need to help these women learn to cook and take care of their families in a more nutritional manner. But I did not consider her to be a very good VBAC prospect. I would not want to run into the catastrophic conclusions of poor diet and poor formation of placenta and a VBAC. It just sounded like it was just too much for me. Weight is also a consideration. We'll talk about that when we talk about, handling women that are, over 300 pounds. You have to have a physical strength to handle women that are over 300 pounds, and there's some special occurrences, and not everybody is going to want to take that. I would not take anybody. I would not take everybody that's over 300 or 400 pounds. There are some women that are sedative when they're that weight, and I would not take them on. That is too much to ask, and I just think if you don't get up and move on a regular basis, labor is probably a bit more than your body can handle. And you need to be responsible. Again, it's that personal responsibility that the parent has to nourish and care for themselves properly. And weight is not always a good evaluation of that. However, it is one of the evaluations for that. So if I do have a very heavy mom, I do kind of evaluate her physical activity. And then I keep in mind that there's consequences there, and there's other things that we have to watch, and we'll cover that in another video. Because this mother graciously is going to allow me to use all of her birth pictures and her birth videos. So there's a lot to uncover there. Please, in the comments, share your experience with the VBAC, personal or otherwise. And yeah, let's get to have this conversation. Let's bring this conversation to the forefront a little bit more, and let's tell doctors they don't get to tell us what we're doing. It's our bodies, and we get to make these choices for ourselves. And let's be aware of what real risks are, and let's start to mitigate those risks. So anyway, thanks again, everybody, and I'll try to get this one posted today.